Good morning, everyone. Thank you for taking the time to talk about STIs with us. We are very excited to be with you for the next 3 days. Just again, a reminder, we are a CDC-funded grant, part of the National Network of Prevention and Training Centers. Our region, as you see here, is all over the place, which is quite exciting. So we're glad, hopefully some of you are from those regions and able to join us today. I have no disclosures, and again, some of our presentations are modified to align with the executive order. I'd like to first acknowledge our team. As Cindy mentioned, we have a pretty big team of clinicians and also public health people to support us. In addition, some of the slides here today were given to us by Dr. Sarit Golub of the New York City Department of Health, and this is specifically around the goals framework that we're going to talk about later today. During this lecture and the next lecture, we're going to talk about STI epidemiology and statistics. In the next hour, we're going to focus on sexual history taking, when, where, and why to take it. In addition, I'm going to present to you maybe a change, a new framework for how to take sexual histories that maybe you can adopt into your practice. So let's talk a little bit about sexually transmitted infections and why they're important. We know, this is data from the CDC, that in 2024, that there were over 1.5 million cases of chlamydia. This, though, represents a decrease in the number of cases of chlamydia since 2020. In addition, there were close to 600,000 cases of gonorrhea, which represent a 20% decrease. Unfortunately, however, the number of cases of syphilis have increased since 2020, with a 42% increase in primary and secondary syphilis, and very extremely important to mention that there was an 82% increase in congenital syphilis to newborns since 2020. So this syphilis and other STIs, of course, has been a huge focus of STI education and also a very big focus for the Department of Health in all of our states. Oops, sorry. So I really want to focus on some of these special populations that are disproportionately affected. We know from the data from the CDC that about 50% of STI cases, so gonorrhea, chlamydia, and syphilis, occur amongst adolescents 15 to 24. We also know that gay and bisexual, as well as other MSM, are disproportionately impacted by STIs. And up to 30% of STIs occur among non-Hispanic, Black, and African American persons. These are populations that are disproportionately affected, and we need to help and understand why and make sure that we're screening, testing, and treating these populations. Not only are the numbers great, but the costs of STIs are great. We know that the direct medical costs are up to $16 billion a year, and up to $1.1 billion was spent directly in treating chlamydia, gonorrhea, and syphilis. So this is a significant cost when you look at all the STIs in the U.S. One of the major problems that we know are that not all STIs are symptomatic. This iceberg is a sort of graphic representation that you can see that the majority of cases of STIs fall below the line. So most are asymptomatic, and specifically asymptomatic amongst women, as you can see here with this figure on the left, the yellow. Some cases are symptomatic amongst men, but the majority are asymptomatic. So this presents a challenge for us in order to detect STIs and then, of course, to treat them. So, as clinicians, we play a huge role in detecting STIs. When a symptomatic patient comes in, we know what to do. We know, okay, here's your symptoms, here's the syndrome you're presenting with, these are the diagnostic tests I'm going to do, and I know exactly how to treat you. But when somebody is asymptomatic, we might not, and we don't recognize that they might have some risk factors, or they might should be screened for STIs. And this is a missed opportunity for detecting STIs, diagnosing them, and treating them. So this is a big part of what we're going to talk about today. So what is sexual history taking? So the definition of sexual history is a medical history of a patient's sexual practices, concerns and illnesses, partners, prevention activities, risk factors for sexually transmitted diseases. It's a short sexual history is recommended at every complete physical exam. So it really encompasses all these activities. So it's a lot to do for the busy clinician. So I want to see if we can launch our polls now. What percent of clinicians take a sexual history as part of every annual exam? Are we going to launch that poll?
Yeah, it's launched.
Oh, the poll is launched. Go ahead, put your answers in.
Right, about 60, 70 people, 70%.
Have answered? And the answer is?
Most people are saying 25 to 49%.
So people say 25 to 49% take it as annual history. That's a pretty good guess. What about patients who report wanting to talk about their sexual health concerns? What do you guys think? Do patients want to talk about their sexual health concerns?
So 44% said 25 to 49% as well.
So very similarly, about 25 to 49% want to talk about their concerns. So obviously there's some things that are making folks not want to talk about their sexual health concerns. So really the numbers show that 6% of primary care providers take a history at every visit. About 55%, and you guys got it right, take it as part of an annual exam. But up to 76% take a history when it's relevant to the chief complaint. So not even 100% when somebody has a chief complaint of a sexual concern. So these are missed opportunities. What about the patient side of it? So 85%, so a little bit more than we estimate, want to talk about their sexual health concerns with their providers. 71% that said that primary care providers should ask all patients if they have sexual health concerns. So they really want to engage with providers around this. But 68% sort of report fear of embarrassing their provider as a reason for not broaching it. So we have a little bit of a disconnect between the patients and providers. So we as clinicians really have the obligation to sort of smooth out that and build our relationship with our patients in order to help them with this and provide more opportunities to discuss sexual health. And why? Because we're missing opportunities. We are missing opportunities to prevent both sexually transmitted diseases and maybe pregnancy. We're missing opportunities to actually improve sexual comfort and pleasure. We're missing opportunities to maybe address other clinical and psychosocial needs that impact somebody's life and their sexual health concerns. Ultimately, these missed opportunities are leading to missed opportunities in reducing community level STIs, HIV, and unintended pregnancies. So we need to address these missed opportunities. And how can we do this? We can do this through improving our sexual history taking. Some of the challenges, however, to sexual history taking are that we really lack an education about how to do it well. It's not taught very well during a medical school or in nursing school, for example. Discussions around sexual health are uncomfortable for both patients and providers. There are definitely time constraints. I know some of you work in practices where it's a new patient every 15 minutes. So how do you fit this in? Sometimes interventions feel very scripted and ineffective. You don't have a relationship with the patient. You're just jumping into something to tell them what to do. And it really is not very effective approach to prevention. So which patients would you take a sexual history from? Well, clearly young adults and adolescents, as mentioned before, close to 50% of the cases of chlamydia, gonorrhea, and syphilis occurred in patients 15 to 24 in the US. But don't forget about seniors. Seniors are also having sex. A poll showed that 40% of seniors between 65 and 80 are sexually active. In addition, maybe they're engaging in practices that might put them more at risk. Another study showed that they have 6% condom use, so lower condom use than the adolescents and young adults. They also potentially are using erectile dysfunction drugs, and there are studies that show an increased association with STIs in this population using these medications. So we can't forget about seniors. It's not moving. Oh, there we go. So where and who, we talked a little bit about who should be have a sexual history taking, but where and how do we do it? So in your practice, you should stop for a moment and think about where's the best place for this to happen. Should it be in the exam room? Or could it be in triage? How do I, think about the workflow of my practice in order to allow this to happen well? Can nursing be involved in this? A lot of times, yes. Nurses in nursing as our partners, they oftentimes have a relationship with the patient and can have that discussion. Do you have access to community health workers? Do you have students in your practice who might help you work through some of these sexual health questions with patients? And then, of course, providers also need to be informed and know how to get this key information from our patients in order to provide prevention, testing, and treatment. There are many different ways, different options of how to get this information. There can be, obviously discussions, which we're going to go talk about in a second, but also self-administered questionnaires. You can have patients complete surveys before they come into their room. You can have a standardized risk assessment form. You can use paper and pencil or make it computerized. Send it to their phones before they come into the office. Need to make it, the new norm as part of your practice. This will help reduce discomfort both for the patient and the partner. It also saves time. In general, we just recommend, starting with get a broad guide. We want you to provide you an approach and help you to pick some words, practices that you feel comfortable with for asking sexual health questions. The key phrase here, though, is ask. We need to ask our patients these questions. We must approach it in a considerate and respectful way, and we must assure them of confidentiality of their answers as we move into this area that often is uncomfortable between providers and patients. So with this information, we want to re-envision sexual history taking using what's called the goals framework. And I'm going to go through what exactly that means and how you can adapt it to your practice. in this re-envisioning, what is going to be your goal? So as a provider, we want you to think about, what do I need to do to understand my patient's needs around HIV testing and STI testing? What do they need? I need to understand their risks. How, and if I understand that, then I can provide education and counseling. By doing all of this, then I can identify interventions. I can offer interventions like PrEP, pre-exposure prophylaxis for HIV, contraception, and vaccines, and more. So this is how this new re-envisioned goals framework works. So why use this goals approach? Well, there have been studies by Dr. Golub and colleagues who've showed that using this approach increases the rates of routine STI and HIV screening. It increases the rates of universal biomedical HIV prevention and contraceptive education. It also increases patient motivation and commitment to sexual health behavior. And most importantly, it enhances the patient and the provider relationship, making it a lever for sexual health and overall wellness. And it streamlines your sexual health history taking, so it can fit into that time crunch that you often are in when you're seeing patients. So what does GOALS stand for? G stands for give a preamble that emphasizes sexual health. O, offer opt-out HIV and STI testing and information. Ask is ask open-ended questions. After asking these questions, you have to listen and get the relevant information. If you need to, then you can probe and sort of fill in the blanks. Finally, you're going to suggest a course of action for the patient, and this includes prevention and treatment options. So let's start with the G, give a preamble. So what's the evidence and the rationale? There have been many studies that show that a common reason why patients don't talk about sexual health is that they feel like they don't have an opportunity. So if you're giving a preamble to talking about it, that opens the door to the conversation. In addition, patients and providers also feel like a risk-based approach is really stigmatizing and it alienates the patients. They're not going to offer up information if they feel like you're judging them, for example, or you're asking them about their risk. Giving this preamble really sets up a quality provider-patient interaction, hopefully then a relationship, with the greatest effect on the patient being that it engages them in the opportunity, and engagement in that discussion actually can set up improvements in adherence, health monitoring, and prevention. So how does the preamble work? What about giving that preamble that focuses on and emphasizing health? It could be something like this. I'd like to talk to you for a couple of minutes about sexuality and sexual health. I talk to all of my patients about this because it's an important part of your overall health. Some patients have questions and concerns, and I want to make sure that I understand your questions and concerns. This will allow me to provide whatever information you need to help you moving forward with your sexuality and sexual health. So as you see from this statement, it's really focusing on health, not on risk. It also normalizes sexuality as part of health. This is part of what I do for everybody, and it's a normal part of health. And finally, it opens the door for questions. It clearly states a desire to understand, to work with them, to provide help, whatever they need moving forward. That normalization is really, really key. Next, you want to offer opt-out testing for HIV and STIs. So what's the evidence and the information around that? I'm going to show you some studies that show that universal HIV and STI screening is more efficient. It's cost-effective versus risk-based screening. When we look at some risk-based screening, it fails to detect folks who need the interventions by 45 or 85% of the eligible patients. In addition, studies show that opt-out screening for high prevalence populations reduces sequelae of STIs, a huge cost of the STIs, by over 37%, and overall reduces STI-related costs by over 20%. So there are long-term and consequences that it can impact, including cost. So what's the evidence? There was a study that was done in 2017, a survey of OBGYNs in New York City, that showed that 47% reported that their patients reported engaging in anal intercourse. 85% reported oral sex. But when another study, so few are reporting it, so we're not detecting it. But other studies have shown, as you can see here on the figure on the left, when you offered universal testing, that it was more efficient than risk-based. So in this study, they looked at RAI as reported anal intercourse. So those who were in the dark bars who did not report it, universal testing detected more cases of chlamydia, so the 8.6% in the UK, versus risk-based screening, 4.8% in the US. So we're missing cases if we're doing risk-based screening, such as reporting anal receptive intercourse. Offering opt-out testing, you say something like, I offer all my patients HIV and STI tests. Do you have any concerns about STIs? This really doesn't commit you to a specific test, and it normalizes it. It sets the idea up that regardless of what they say, you're going to offer it. It sort of also opens the door to talk about other concerns with regards to sexuality and sex. Asking an open-ended questions, not a yes-no question that sometimes is easier to ask, is actually more efficacious. And what's the rationale around that? Standard risk questions are often stigmatizing, as we keep mentioning, and often doesn't predict the exposure. As we saw, patients did not report that they potentially had anal receptive intercourse, and yet we detected chlamydia there. I often have patients who say, I haven't had sex in 6 months, and lo and behold, when I do universal testing, the tests come back positive for STIs. The objective risk scores are not associated with risk perception by these patients. So often we're not picking it up. They don't understand, or they don't really feel like this is picking up, or it's not estimating their risk well. Closed questions may lead to misunderstanding, may make patients feel that you're, again, judging them. And it really doesn't pick up their actual practices around what they're doing in terms of their sexual practices. So here's some evidence that, again, looking at PrEP eligibility and asking those open-ended questions or not. In this study, they use the risk-based scores for assessing whether somebody is eligible for PrEP. And they found that they missed many opportunities. There's both the CDC risk score or the HRIRI score, and these are based on sexual practices, men who have sex with men, substance use. And when they used this among patient populations, they looked at how many seroconverted to HIV or not, and they found that only 40 to 80% of the populations who were evaluated were eligible for PrEP. So this is a small number that potentially then led to seroconversions. They also found in this study that young Black MSM were least likely to have an indication for PrEP. So we're missing opportunities because folks are not responding to the risk-based score when asked those risk-based questions. In fact, seroconversion was more strongly linked to zip code and social networks than it was to the risk assessment. So asking open-ended questions sort of puts the focus on the patient. It lets you hear their concerns what's most important to them. And it also then allows you to identify language that they feel comfortable with. So how do they feel comfortable talking about body parts, partners, and practices? Asking these questions can be something like, so tell me a little bit about your sex life. What concerns do you have about your sexual health? Or how is your current sexual health different? Or what would your ideal sexual health be like? After asking those questions, you have to take a beat, you have to listen, you have to understand and hear what they're saying. It has been shown that listening and asking those open-ended questions actually reduces the time needed for sexual health and allows you to focus specifically on their concerns. It also reduces your bias by mirroring their language and using non-gendered terminology. So what can this look like? And if we're using, for example, the 5 Ps that the CDC talks about when getting sexual health information. The 5 Ps stand for partners, practices, prevention of pregnancy, protection from STIs, and past history of STIs. So for example, you might say, tell me about your partners, or more relevant, you might say, tell me about people that you're having sex with. There's no assumption by this statement about identity, male, female. What concerns do you have about sexual health? Or what types of sexual activity do you engage with, specifically oral, anal, or vaginal sex? You need to ask, those questions specifically, especially I find with the younger population, because oftentimes they won't discuss which areas that they're exposing their genitals to. Prevention of pregnancy can be talked about regardless of identity. So how do you prevent getting pregnant, or do you want to have children? We want to know, how do you protect yourself against HIV and STIs? It helps you understand their motivation, their self-determination. What's been your experience with condoms? People have very strong feelings about condoms, and definitely they have strong feelings about condom use for oral sex, which needs to be explored. Past STIs are really important to assess. So, have you ever been tested? That's really important to know, because a lot of folks are not tested. So this will reveal to you to engage in that. And it also, you'll learn about later with syphilis, how that's important, getting that first test on the books. You want to know, for example, sometimes they don't even know, but you can say, have you received treatment like pills or an injection for a sexually transmitted infection? After you ask these questions, you want to listen to what they say. There is an expansion of the 5 Ps that you could think about as well. There are psychological issues, prevention issues such as people using PrEP for HIV, prevention of STI, for example. Is somebody using doxypep, or have they received immunizations that might prevent STIs? That's important for you to be able to assess. So psychological issues we know impact sexual health and sexual practices. Substance use we're going to talk about in a second, but also folks may engage in survival sex. They may be victims of sexual assault or intimate partner violence that may lead to sexually transmitted diseases, or have a history of incarceration where we know STI rates are higher. Substance use, when you're asking a patient, sometimes they say, hey, why are you asking me this question? Well, it can impact a person's decision to have sex or who they have sex with. They might be participating in chemsex, so parties with substances, for example, in order to intensify their sexual experiences. As I mentioned before, folks might be using erectile dysfunction drugs to help them because of disinhibition or because of erectile dysfunction with sex. And we know that in the use of some of these drugs, you may expose yourself to STIs that you might not have thought about. Intimate partner violence is unfortunately common. We want to know with patients, has this ever happened to you? How do you feel safe in your relationship? We know that, a third of minority males and half of sexually minority females report being victims of psychological or physical abuse in a romantic relationship. This has been associated with STIs, and you need to understand that. So after we ask all these questions, we need to take this information and create a plan. We need to suggest a course of action. So what's the rationale about suggesting a course of action? Well, we know from studies that, if a patient has a belief in the benefit or the efficacy of your intervention, they're more likely to strongly associate with the adoption of that behavior and engage in that behavior. There's more patient self-efficacy in that they will uptake what you're hopefully suggesting, their adherence might change, and you have more sustained sexual health behavior for the patient. Universal PrEP, discussions around PrEP and contraception can also increase community awareness. For example, and I don't know if those of you who watched the Knicks game, there was actually PrEP, HIV PrEP was one of the commercials that happened during that game. So we want to suggest a course of action. So what should be the content of that? A big part of it is testing, but prevention and education is also incredibly important to engage in. So you could say something like, thanks so much for having this discussion around your sexual health. I'd like to test you for whatever you're going to do. So focus on universal testing. We're going to talk a little bit more about 3-site testing because maybe in the course of your sexual history testing, you identified that somebody has oral and anal intercourse, so you're going to test at those sites. And you're going to offer it universally to everyone. If you set this norm up, your patients are going to come in asking for that. And that's what I've found in my clinic. You might say something like, I'd like to provide you information about PrEP and contraception or doxy-PEP. I think it would be really helpful for you. So focusing on what's healthful behavior for them moving forward. You are making this activity to help you in the future. And then you could say something like, well, I'd like to refer you to the counselor or health educator in case you have other concerns. This will help you with time management. It also focuses on education, self-efficacy, and it can be provided universally to everybody. So making it non-stigmatizing. So in terms of goals, how much time does it take? Really? For most of it, it takes a minute for each bullet. So giving that preamble, offering opt-out testing, asking the questions. How much when you're listening, that might take a little bit more depending on what the patient ends up wanting to talk about. And you might get into some situations where you definitely need some help from your counselors who would be available. And then suggesting a course of action, really just 1 minute. So this can all be fit into 5 minutes, and then the listening part takes a little bit longer. The strength of this goals approach is that it's data-driven. It removes the traditional risk assessment part of sexual history taking. It focuses on building your patient-provider relationship, and it normalizes the sexual health discussion. It's designed to be specific about sexual health concerns. So it allows you to make it universal, but focused in on sexual health. And it reduces your bias and allows you to offer HIV and STI screening sort of universally, and universally providing education around sexual health with options about prevention and strategies beyond condoms. So let's take a patient, for example, how would you roll out this goals approach with this patient? So Ricky is a 22-year-old. He's formerly incarcerated. He's coming in for a pre-employment physical. Using this goals approach, you think about your preamble. How am I going to emphasize sexual health? How am I going to roll in the universal or opt-out testing? So you say, hey, Ricky, so glad you came in today. That's great, let's get you moving on as you're starting on a new path. I want to talk to you a little bit about, your sexual health. I do this with all of my patients. Tell me about your partners or people you've had sex with over the last 3-6 months. What kind of practices have you been engaged with? Do you have oral sex, anal sex, vaginal sex? Moving forward, are you interested in having children? What has been your experience with condoms? Do you prefer one type or another? We have some in our clinic now if you'd like to take them, but we can also talk about other approaches to protection on STIs. We have a new medication regimen called DoxyPep. Maybe you would be interested in that. Have you had other STIs in the past? Gonorrhea, chlamydia, syphilis, maybe gotten a shot or taken those 4 pills? This allows you then to go through each of those phases. So give the preamble, offer the testing, ask about questions, listen to the approach, and suggest a course of action. So he tells you he's 17, he has a partner who's 17, so similar age range. He practices oral sex, he denies anal and vaginal sex, yet he doesn't use condoms, but he's using them. He's not really sure, not all the time. He's not interested in having children right now. He has never had STIs, but actually he's never been screened. So this gives you then opportunity to offer him a plan, suggest your course of action. So Ricky, given what I've heard from you today, I really feel like we should offer you, STI testing. I offer this to all my patients. Let's give you some HIV testing as you move forward. You'll know what your status is. STI screening is really important. We test everybody for STIs at the sites where they engage in sexual practices or for the future where you might be having sex. So I would like to offer you testing, oral, anal, as well as urine testing. Syphilis testing with an RPR is really important in all my patients. Let's also do that as well. General health screening like quantiferin can also be done. I'd like to offer you screening for hepatitis C today. In some states it's mandatory for each touch the patient population has with the healthcare. I'd also like to provide you vaccines that can prevent hepatitis A and B, as well as vaccines to prevent warts like human papillomavirus or Mpox. Today, I'd like to discuss a little bit about prevention. So what can you do besides condoms? Maybe DoxyPep would work for you. Let's have a discussion about that. Or HIV PrEP is really important. Why not prevent it? There's some really easy things you could do, either a pill or injections. Maybe I can refer you for some more information moving forward. We do have a social worker in clinic today. Would love to have you engage with them to discuss this further. So that took, less than 5 minutes? Really, really important and super easy to do. So why just a little bit to go over this 3-site testing? So this is a study that was just published in STI. It looked at 3 patient populations. So MSM, men who have sex with women and women. In these populations, it looked at the chlamydia positivity rate, and you could see by the arrows that if you hadn't tested at the anogenital region, you would have missed 12% of the population with gay and black MSM. You would even miss men who have sex with women, 10% of the chlamydia, and for women, you would miss 10% as well. When they looked at gonorrhea positivity rate, even more. So anal and oral infections were missed by not testing would have been missed if you hadn't tested at those sites. So super important to test and think about 3-site testing, and we're going to go over that too in our next presentation. So a couple of take-home messages today for everybody. Sexual health needs to be part of your regular history taking. If you ask early and ask often, and each touch with the patient population, you're going to get more information. You're going to build your relationship with this patient population. Use an approach that you feel comfortable with and practice it. The goals framework, give the preamble, offer up that testing, ask an open-ended question, listen, and then suggest a course of action. Super easy. Can flow off your tongue once you figure out how to do it. And it allows you to have this as a normal relationship, focus on health and health behavior as part of sexual health. And the information that you get can really drive your clinical evaluation. It can impact and your prevention that you're discussing, your management strategies. It's not just about STIs, but also other aspects of sexual health, like contraception, for example, vaccines. We don't want to forget about vaccines, HIV prevention, and doxypep. In addition, it could open the door to assessments and linkages to care like mental health support that's so important for our patient population. We know so many folks struggle with this, and it's really important for us to have that also be part of this whole process. I want to thank you today for listening to our initial discussion about starting off our 3-day educational series on sexual health, about sexual history taking.
Great. Thank you so much, Dr. New, for that wonderful presentation. We're going to move to the Q&A section.
Yeah.
So for those who have questions about sexual history taking for Dr. New, please drop them in the Q&A box located at the bottom of your Zoom screen. I'll kick us off. We've heard this a few times before. Can providers just offer STI testing without asking some of these questions? What are your thoughts on that?
Sure. Definitely you can offer STI testing without asking all the questions, but it's really important to have that conversation, because having the conversation will allow you to then implement education, for example, around prevention, and offer other things. I think if you're going to do something for a patient, you really need to tell them what you're doing. So I would really recommend having that conversation first, and it builds your relationship with them moving forward, and really makes people feel like you're invested in them, which I know you all are.
Wonderful. Can you talk more about separating adolescent patients, from their parents when talking about important topics like sexual health, mental health, or other concerns?
So that is a really hard task. I always say to my patients when they come in with their parents, I might start with, thank you so much for coming in. Really want to hear your point of view about why you guys are here today. But I also need a little bit of time to speak with, your child, one-on-one. I do this for all my patients. So again, normalizing it, universalizing it. And, I always ask my parents to step out of the room when I do my physical exam on this patient population. It's also a way of you allowing them to gain some independence. So I'm helping you in this journey to help your adolescent gain independence. And whatever information we get, we'll discuss, moving forward as part of our action plan.
Wonderful, yeah. We have one question in the chat. Oh, actually, it was just a comment about how this person is new to sexual health care provision, and this training has been great in helping them step it more into that role. So thank you for that.
That's our goal.
Yes, yeah, with these trainings, yes. So, what other tips do you have for providers who are, still concerned about time management when it comes to sexual history taking?
So I think practicing this and doing it more often and using a framework, like we train in med school and nursing school on frameworks and establishing a pattern so that you don't forget things, like the soap note, for example. I think it's really important to take sexual history and put it in a framework that allows you to not miss things and to make sure that you touch on each point. And as I mentioned, really just takes 1 minute. I talk about this with all my patients. I offer everybody universal testing. And then listening. I mean, yes, listening can get you into trouble sometimes, but have a backup, or always saying, what we're talking about here today is super important. I'd like you to come back so that we can really focus on that. So it doesn't mean you're not going to address it, but you're going to set up a time to really address it, potentially with more time later.
Great. So I don't currently see any questions in the Q&A at the moment, which is totally fine. As questions come up, you can drop them in the chat and we can address them either later today or tomorrow morning for our next day. So thank you so much, Dr. New, for your presentation on sexual history taking. Now we are actually going to launch those introduction polls I had mentioned earlier, just to get to know our audience a little bit more. So just bear with me while I pull those up. All right, so everyone should see the 4 questions. So we honestly would love to know where you're joining from, whether you're in our region or outside of that, what your role is, how much of your clinical time is spent providing sexual health services, and if you're attending today's training as a refresher or as an introduction to sexual health care. So thank you all for your contributions.
Woo-hoo, the great state of Michigan.
All right, so we have about 2/3 of respondents answering and can, share those results after. So it looks like a good portion are attending from Michigan. We have folks from New Jersey and New York, Indiana as well, and then outside of the region. For today's training, a lot of folks are nurse practitioners. We have PAs, nurses, DIS DIS. And a good portion of people, half of the attendees today are actually providing 75 to 100% of their clinical time to just sexual health care provision. So that's wonderful.
That's amazing.
Yeah. And 4/5 are here for a refresher. So that's wonderful. Thank you so much for your contribution today. We're actually going to do a short break. It is currently 9:39. We will reconvene at 9:50. We're just going to give our speaker a short break since she's also going to be presenting on STIs 101 here shortly. So take a break, get some water, stand up and move around, and we will come back at 9:50. Thank you.